fine. But I'm just shivering. I feel so cold.
Do you have diabetes?
No.
Do you have hypertension?
Doctor, why you are wasting time asking all those history? I already told you what is the case
so
about.
cold. I feel so cold. I have asked more blankets. I just can't be here. I feel so cold.
It's okay.
And
So make it fast, na?
Yeah,
and I'm not okay.
He said it.
I'm not okay.
Baby is already having 120 fetal heart rate. Just drop into 80. Why you are wasting time?
I'm not feeling right, doctor.
That's what I told you.
This is you talk. Yes, my voice is very good because her.
Do you have hypertension?
Doctor, why you are wasting time?
I'm just not.
I already told you everything regarding the case.
I'm
Yeah,
not
ma'am.
feeling okay, doctor. I'm so cold.
And do you have any asthma?
No.
Do you have any COPD problem?
No.
Do you have any heart disease?
No.
Fetal heart is already dropping to 80.
Yeah,
Why you are wasting time?
Yeah, ma'am, we are sedating the patient. Now I'll make her to sleep.
Doctor, I'm not so okay. I feel so cold.
Yeah, ma'am, we are making the patient to go to sleep. You have sedated the patient.
Shall I start the test? Shall I put the incision?
Yeah, ma'am. 1 second, we shall check the patient.
Oh God! Where is the senior anesthetist, please?
Can you feel the sensation?
Yes.
How come the juniors come for the case?
Mask remove the please.
She only will.
Breathe properly, sir. Keep the mask on. Put the mask on. Put the mask on.
Mrs. Gupta, are you under any medication?
No.
Any medicines you are taking?
Hey, come on, yeah.
No, actually, no.
No?
No.
Okay.
But
Are you
I
feeling
was
sleepy?
taking some medicine for my fever.
Okay, are you
Do
feeling
it fast,
sleepy?
ma.
Yeah, can you feel any sensation?
Yes.
Do you feel like something is touching you? Perfect. Perfect. Stop on your uterus is well contracted. Okay. You just give some fluids, I think. Can I have, what was the hemoglobin before we came?
Hemoglobin was 10, ma'am.
10. Okay, alright. Please mask it.
It is with immense pride and pleasure that I stand before you today to welcome you all to the workshop on obstetric simulation and anesthesiology. This is a subject of critical importance not only to us as an anesthesiologist, but to the entire healthcare system as it significantly impacts the maternal and neonatal outcomes. To start with the session, we'll start with our Tamil Word. I would like to introduce the dignitaries on the dais. I would like to welcome our Director, Dr. C. Uday Shankar, Director, IGMC and RA. Welcome, sir. Next, I would like to welcome Dr. I. Rajesh, Joseph Rajesh, sir, our medical superintendent. I would like to welcome Dr. Hemanth Kumar VR, HOD and HOD Anesthesiology, IGMC and RN. I would like to extend my welcome to our chief guest, Professor Makhani Purva, who is an internationally renowned expert in simulation-based medical education. Welcome, madam. I would like to call our professor, Dr. R. Ravindra Bhatt, to deliver the welcome address. Good morning, everyone. The onset, actually, I start with apologies from our HOD, Dr. Pratibha. She was supposed to be here. She has been instrumental in organizing this program, as she had to attend to another program which was rescheduled because of the Ahmedabad plane crash. She is not able to attend this. So with this note, I will start. Good morning. I respect the director of our institute, esteemed and honorable medical superintendent, Dr. Joseph Rajesh, our distinguished chief guest, Professor Makhani Purva, respected dignitaries, Dr. Hemanth Kumar and Dr. Rani, and fellow anesthesiologists and dear colleagues. It is an absolute privilege and honor to welcome you all to this workshop on obstetric stimulation and a platform dedicated to enhancing our skills and sharing knowledge and fostering collaboration in one of the most dynamic and critical aspects of anesthesia practice, that is obstetric care. First and foremost, I extend my deepest gratitude to our director for his continuous encouragement and visionary leadership, which makes such an academic and skillful development programs possible, Dr. Udeshwar sir. I'd also like to acknowledge the unwavering support of our medical superintendent, Dr. Joseph Rajesh, whose contributions to elevating the patient care standards in our institutes are truly commendable. We are indeed privileged to have among us today our chief guest, Professor Makhani Purva, a renowned expert and an inspiration in the field of medical simulation. Madam is a consultant anesthesiologist in Hull University Teaching Hospital NHS Trust and Professor of Simulation, Hull York Medical School, UK, Founder Director of Simulation at Hull Institute of Learning and Simulation, the largest simulation center in Yorkshire. Professor Purva is past President of Association of Simulated Practice in Healthcare in the UK. She was the lead author of the first simulation standards in the UK. She also developed an accreditation process to enable self-program and organizational accreditation. She was one of the first to establish a postgraduate MSc course in simulation in collaboration with Hull University. Professor Purva is on the editorial board of the Journal of Healthcare Simulation. Her research publications focus on in situ simulation modalities, curriculum mapping using simulation, and use of simulation to reduce the learning curve. Your contribution to the medical education and innovation have set benchmarks for us to aspire to. We eagerly look forward to your insights and wisdom, madam. Additionally, I am delighted to welcome our distinguished guests, Dr. Hemanth Kumar and Dr. Rani, whose expertise and dedication to advancing anesthetic care are well known in our fraternity. Your presence greatly enriches this occasion. This workshop aims to address the complexities and high stakes involved in obstetric anesthesia by integrating advanced simulation techniques into our practice. Simulation-based training not only hones our clinical and crisis management skills, but also fosters teamwork, communication, and preparedness for rare yet critical scenarios. As we embark on this enriching journey today, let us remind ourselves that the ultimate aim of all our efforts is the safety and well-being of the patients who entrust us with their care. I urge each one of you to actively participate, exchange ideas, and make the most of this workshop. Together, let's commit to advancing the field of anesthesia through innovation, collaboration, and continuous learning. Thank you, and I hope all have a productive productive and enlightened day ahead. Thank you. Now, I would like to call our medical superintendent, Dr. Joseph Rajesh sir, to felicitate our director. I would like to call again our medical superintendent to felicitate Dr. Makhani Purva, who is the chief guest of the program today. I would again like to call our medical superintendent to felicitate Dr. Hemanth, HOD Anesthesiology, IGMC CME. I would like to call Dr. Ravindra Bhatt, Professor of Anesthesiology and IGMC to felicitate our medical superintendent. So just a minute. I am Dr. Ravindra Bhatt to felicitate Dr. Rani, Professor of Anesthesiology, IGMC. I call upon Dr. Rama Devi, Associate Professor of Anesthesiology, IGMC to felicitate Professor of Anesthesiology, Dr. Ravindra Bhatt, IGMC. Thank you, dignitaries. Thank you, everyone. First and foremost, I would like to express my deepest gratitude to our esteemed director and our medical superintendent for their invaluable guidance and support in making this event possible. Your leadership and vision continue to inspire us to innovate and excel in our academic and clinical pursuits. Our special thanks to our medical superintendent, Dr. Joseph Rajesh, for this constant encouragement and logical support which have been instrumental in organizing this program. I am profoundly grateful to our distinguished chief guest, Professor Makhani Purva, ma'am, for honoring us with your presence. Thank you, ma'am. Ma'am, your thought-provoking address today will be a compelling tone for this workshop and remind us for the transformative potential of simulation-based training. Our heartfelt thanks to our dignitaries, Dr. Hemanth and Dr. Rani, professors from MGMCRA, for taking the time to be with us and for this invaluable support and encouragement. Your presence enhances the significance of this event. Thank you, sir. I extend my sincere thanks and appreciation to all the organizing team members and who have worked tirelessly behind the scene to ensure the smooth execution of this event. Your dedication and hard work are truly commendable. Thank you, everyone. Finally, I would like to thank all the participants and attendees who have gathered here today. Your enthusiasm and commitment to advancing our field inspire us to organize such events in the future. As we move forward with the session planned for this workshop today, let us continue to engage, learn and innovate to enhance the quality of patient care in obstetric anesthesia. Thank you all once again for making this inauguration a memorable occasion. Wishing you a productive and enriching workshop ahead. Thank you. Call upon our director, Dr. Uday Shankar, to felicitate and give a memento to Dr. Makhani Purva.
I'd just like to thank the team leader, Mr. Prem, and Saraswati, who is here, who are also vital for today's workshop. They are all the SIM technicians. I've been associated with them for a long time, and you are going to see the simulation just because of their contribution, which is the most vital thing.
Good morning, everyone. Firstly, can I just ask, because we seem to be unevenly distributed, the left side of the room seems to be empty. Can you move to the people at the back, if you can just move? So I can this side and so I don't feel lonely on the left side. Learning. Because if the learning experience is enjoyable, you're more likely to retain it as well. This is not an exam. It is interactive. It will be an interactive entire day. There will be plenty of questions. There will be plenty of new information. But more importantly, this is a very new style of learning. I know some of you are already exposed to simulation. Can I just have a show of hands? How many of you are exposed to simulation learning? One, sort of half. No, there are more hands now. Wonderful, excellent, very good. So today is going to be, and for those of you who haven't experienced it, it is an opportunity to see a different style of learning. So I come from an organization where we do a lot of simulation, and because I'm passionate about simulation, I do it as part of the learning, and it's a continuous exercise. Okay. So what I will say is, we can close that door because then there isn't any noise. Okay. Close the door. Anybody who's speaking can go in there and yeah. Okay. Right. So traditionally what I do is to have a quick round of introduction, so you know who I am, but I don't know who you are. All of you have done already two things. One is you filled in a pre-course questionnaire, is that right? That sheet about your confidence levels. If I can use this. So, yeah, you've done this. All of you have done it. If you haven't done it, please do it right now. Okay. Can I just ask the two of you to sit next to this lady? Thank you. All of you have completed what your objectives are for today. You all put your okay, wonderful. So what I'm going to do is a quick round of introduction. All I want to know is your name and where you are from and what your actually you all will need this part of the company. Wonderful. Yes. Pass on the mic as you go on.
Myself, Dr. Hemanth. I'm the first year postgraduate student from IGMC CME. I'm Yoshi, first year postgraduate from IGMC. Myself, Chandrika, first year postgraduate from IGMC.
Okay, so all of you have sat together according to your institution. I will break this up. You've got to sit with somebody you don't know. No problem. Carry on.
Dr. Hemanth from India today, final year.
Right. Right. I'm Dr. Hemanth, right. Okay. It's not working. Oh, that's fine. Excellent. I'm okay. Okay, all also sitting in the same thing. Yes. Okay, all right. Nice. Oh my God, your fan is somebody that you don't know that. Very good, excellent. Right.
Good morning, all. I'm Dr. Hemanth, second year postgraduate at IGMC.
Nice.
Thank you, Ruba, first year NSC.
Dr. Hemanth, final year NSC.
Right. Sir.
Dr. Siddharth, final year resident.
Right.
Dr. Gautam, final year NSC.
Right. Dr. Harni, final year resident and right.
Dr. Hantika, final year NSC.
Oh, excellent. So what you say, there's one, yeah, otherwise you'll be on your own. That's fine. Excellent. Okay. So what I've has everybody, have you put your sticky? I think the two of you haven't done your sticky notes. So fill in the sticky notes. Team and communicate in an emerging crisis situation. Communication, a lot of it on communication. I'd like to learn about common anesthetic considerations and obstetrics. Wonderful. How to manage a sick patient effectively, how to analyze the situation in crisis, how to plan further course of action after managing a sick patient intraoperatively. Would like to learn about management of emergency situations in obstetric anesthesia, how to communicate, manage difficult cases. Communication turns up quite a lot. Okay, that's brilliant. So firstly, I can say that you are in the right place, you are in the right course. Because if you were expecting anything other than what is there in the company in those outcomes, I would have been worried because you would be in the wrong workshop. Okay. So what I wanted to do with you all today is to give you a very practical demonstration of what a difficult day as an obstetric anesthetist will be. So you're going to be put through various scenarios. Now before I come to the scenarios itself, I just want to spend about 20 minutes going through something that I think is an approach that you're aware of. So how many of you understand this term human factors? Human factors? Anybody has heard about it? Right, okay. The second question I wanted to ask is, how many of you know about a particular case that happened in the UK about 15 years ago? It's called the Elaine Bromley case. Yeah? Do you remember that? Can you tell us what it was about?
Sure.
Okay, I'll remind you all about it. Okay, so Elaine Bromley was a young mother of two who went for a nasal septum related procedure, day case procedure. The anesthetist was a consultant anesthetist with 18 years experience. The ENT surgeon was an ENT surgeon with 22 years experience in ENT. They induced an average day, working day, 9 o'clock in the morning, first case. He tried to put in the laryngeal mask, he could not put it in. Over a period of the next 40 minutes, multiple attempts were made to securing the airway. Attempts to intubate were also done, which did not work. And then 40 minutes later, they abandoned the attempts to intubate or secure an airway and then shifted her to the ICU. At that point, they then did an intubation. She then stayed on the ventilator. She already was brain dead by then. 2 days later, they disconnected the ventilator and she passed away. Her husband, Martin Bromley, was a British Airways pilot. Now, the inquest happened, a lot of questions were asked, but what he did very surprisingly was, he decided to look at his wife's death as a learning opportunity for the healthcare in the UK as such. Now, this didn't happen very long time ago, it was only in 2007 this happened. What he found was that if you are an airline pilot, every 6 months you get into a simulated cockpit, and if you do not complete all the responses to emergencies, you cannot get into your next airplane. Whereas as clinicians, whatever specialty we are, once you finish your MD or even your MBBS, that's it. Nobody asks us a question. We are licensed to kill after that. So he then raised the query as to why in healthcare we do not have an opportunity to practice the drills that are relevant for emergencies. And if you look at for an anesthetist, what is the #1 drill that we should be practicing? What is the most important emergency for us? Which is the emergency you most dread as an anesthetist? Airway. So if that's the most important emergency, then shouldn't we be practicing it on a regular basis? So let me just ask you, when so the failed intubation drill, let me ask you how many of you have practiced it in the last month? 2 months? 6 months? 1 year? For those of you who have been practicing anesthesia for longer than a year, in the last 2 years? For those of you who have been practicing anesthesia for longer than 2 years, in the last 3 years? I mean, if our patients were aware of this information, how safe do you think they would feel in our hands? If you were a patient and you knew your anesthetist has not practiced a failed intubation drill in the last year, 5 years, how safe would you feel? So, it is not anymore an option. It is our responsibility to be safe for our patients. So what you're doing today, you can tick the box today because all of you will have rehearsed some of the emergencies. But that is today, 22nd June. Ask yourself the question, when are you going to practice next? Alright? Now, if I asked all of you the failed intubation drill, to write it down on a sheet of paper, I can guarantee you will write it down. The problem is not content knowledge, it's the application of the content knowledge. And this is where the human factors approach comes in. The human factors approach, and I'm going to run through a few definitions. It's a bit of a technical exercise, but I will try and make it as interactive as possible. So, we're going to talk about errors in the workplace. All of you will have an opportunity to make a mistake today. The reason you're going to be able to do that mistake is because only when you make a mistake, you will learn it. If you make a mistake, you'll remember it for the rest of your life. So every person who has been through an error is likely to gain a lesson that will help the next patient. But imagine if every one of you have to do an error before you gain it, how many patients will be harmed? So let me ask you the question, how safe do you think the healthcare environment is? Right, you can't sit on the fences to answer. Okay, the next question, how many of you, so you know this driving on the roads, let's compare driving on the roads and healthcare. How many of you think driving on the roads is safer than healthcare? Okay, so therefore, how many of you think healthcare is safer than driving on the roads? Raise your hands. No half and all that. Anybody sitting on the fence? Ma'am? Is it because you think you're an unsafe driver that you're not raising your hands? Well, I'm an unsafe driver, but yes, okay, right. Okay, next question. So remember this, okay, all of you have said that driving on the roads, healthcare is safer than driving on the roads. Agree? Yeah? Okay. Next question, bungee jumping. How many of you have done bungee jumping? Wow. Only the two. You've got two adventurous people here. Alright. So, how many of you think that bungee jumping is safer than healthcare? How many of you think healthcare is safer than bungee jumping? Wonderful. Right? Let me show you. It's time to reveal the answers. Okay. Ultra safe. Aviation. Okay. Driving. Dangerous. Mountain climbing and bungee jumping is safer than healthcare. Now, every time I put this slide up, people will say, and I'm sure this thought is going through your mind, I do not know about this person sat next to me, a theatre who should belong there, but not me. This is a fallacy. We are only as safe as the weakest link. Until all of us become ultra safe, we cannot move from here to there to there. Right now, the level of errors in our healthcare is so high that we are the most dangerous category. And this is data, well proven. There is no question about I am safe. This is a fallacy. Because we constantly think only about ourselves and not as a team, we fail as a team. And when we fail as a team, we fail our patients. And that is what we're going to be looking at today. How we fail as a team. You will fail on your own, you will also fail your team, and your team will collectively fail. So that is the part, that is the most important learning that you're going to take away today. The issue we have is, and this is something I have said to Sir, and I want you to, the intention of today is to make you uncomfortable, but uncomfortable in a safe, a psychologically safe place. I'm aware, although I don't live in this country, having lived in this country for over 30 years, I closely follow what happens here. I'm aware of all the issues you have with the physical violence that is happening against doctors, which is completely unacceptable. Completely unacceptable. What I'm going to say next is provocative, and I apologize for it ahead of time. But what I will say is, we have arrived at this situation not only because of our patients, but also there's been some contribution from us as healthcare professionals. There are very, many ways of diffusing a situation, preventing a situation from arising. It cannot happen by legislation alone. It cannot happen by brute force alone. It has to happen by a cultural change. The next generation of the environment, the next generation of doctors, the next generation of our population has to change in its approach to each other. And what we're talking about human factors approach today, you will have an opportunity today to also witness and manage a difficult situation, because it all comes down to communication. So communication is not only internal but also how we do it externally as well. Now, Sir has said this many times, and I'm going to just, I wanted to have this slide because a lot of things happen, and all of you, and do you remember what I said? If I ask you to write down the failed intubation drill, you will write it down. Yeah, so there's no problems with technical knowledge. It's the application which is a problem, and that application is loosely said as non-technical skills. So if I were to ask you to attribute technical and non-technical contribution to the error, out of 100%, how much is technical contributing to the error? Give me a rough percentage. So if an error happens, lack of knowledge obviously contributes to the error as well. And non-technical is everything else, you know, situational awareness, teamwork, leadership, communication, all those sort of things. So what percentage would you attribute to technical and what to non-technical? But easier for me to ask you first technical. So what percentage contributes to an error? 0%, 5%, 80%, 90%, 100%, how much? Just call out a few numbers, just take a guess. 10? Anybody more than that? It's like an auction. Anybody more than 10, less than 10?
25%.
25. Anything more, less? Okay. Absolutely right. Because what you find is content knowledge is what makes a very tiny contribution to human factor, to errors. Now, what I want to also tell you is, and it is, I'm not for a moment suggesting that you turn up at work or for your exams and say, actually it's only 20% is content knowledge, so I'm not going to read for my exams, I'm just going to manage by being a good communicator. No. There's an assumption that you know what is the management of obstetric hemorrhage, what is the management of preeclampsia, whatever. But what we are saying is, we don't practice application, and that is the non-technical side of things, and that's all. Now this is where human factors comes in. That non-technical, all those non-technical factors we're talking about comes into what we call as the human factors approach. So the word human factors is sometimes misused because people use it for exactly the opposite of what it means. Human factors is not about the human being. It is about the factors that influence how the human being works, which is everything else around that human being. And I have a lovely diagram to show you for it. So remember that human factors is not about human, it is about the factors that influence how the human works. And we will look at the definition as well. So, the definition itself. So when I said it's everything else, it's the environment, it's the organization, the job factors, which influence how you behave. So today, in the simulation that we've created for you, we are going to provide you very different environmental factors. We are going to make you work in a hospital where you're supported and not supported. We are going to make you work in a job that is stressful at times. So we're going to give you all the different combinations which will influence how you behave. And from that, you will learn what's the right behavior, how to cope for stress, how to make sure that your job does not influence what happens to your patient. So it gives you an opportunity to be aware of what the issues are so that you can address it. The next diagram is what helps you to understand that. So you as a person interacting with your machine, anesthetic machine, is influenced by how your theatre and the people around the theatre behave. But more importantly, it also is influenced by what your organization, does your organization provide you the right breaks? Do they provide the right policy? Do they provide the right protocol? Do they provide the right equipment? So when the equipment fails, do they replace it? All those sort of things. There are some you can influence, some you can't influence. But where you can influence, how do you make yourself in the best possible place for you to apply your content knowledge in a safe way? That is what the focus of today's meeting. But how does that cause an error? Swiss cheese model is something that you might have heard. Now it's very interesting because Swiss cheese is such a European concept. Basically it's a piece of cheese with holes in it. So you remember what I said right at the start when I said I am a very safe person, all the other people are unsafe. And I said you're only as strong as the weakest link. The reason being, I'll give you an example. Let us say that you are going to put up, you prescribed IV fluids. The nurse goes and brings IV fluids and puts it up. 10 minutes later, the patient is dead. The reason being, it is potassium that was put up. So if you're working in an organization, an average organization, there will be an investigation. What will happen at the end of the investigation? What will happen to the individual involved? Let's say the nurse. What will happen to the nurse involved? Should be suspended, correct? So let us take the story a little bit behind how it actually developed. 3 days earlier, the requisition went out to the pharmacy to replace all the fluids. The person who took it to the pharmacy was a new porter. He just came for 1 day. It was really a one-off contract. He was asked to collect the saline. Then as he was going, because he didn't have another porter, they said, can you also drop all this potassium in the ICU? In his wisdom, he decided that rather than taking two days, because anyway the lift doesn't work, the lift takes a long time to come, you can't go up and then come down, go up and come down, so he took both in the same trolley. And then when he went to the ward, he knew which one to deliver, but normally the nurse is the one who takes it. That day there was a shortage of nurses. So the nurse said to him, you leave it in the cupboard and you go. So he left it and went. You as a doctor, 2 days later did the prescription. Normally you should check with the nurse before it is put up. You get called for an emergency. The nurse goes because there is an anaphylactic reaction next door, because there is some patient who is not well. So she tells the student nurse, collect the bottle from the cupboard and put it up. She puts it. So who's to blame here? No one. Excuse me. Do you run a hospital, my dear? We always blame somebody. So who are the people who are involved in that sequence of steps? Can we call out the names? Porter, nurse, which nurse? Staff nurse, student nurse, doctor, organization. And who finally gets the blame? Doctor usually, student nurse, whoever's the easiest scapegoat. So, when all those holes, so at every step, it could have been stopped. But when every hole lines up, you get an error. So this goes back to what I said. So if you have a checklist, there is a reason for a checklist. You do not deviate from it. There is a reason for a double check, you do a double check. If you have to make sure that there isn't anybody there that day, you do not do that particular act. You wait till you find another person. So there are safety checks at every stage. So you follow. We are lazy sometimes, or we get distracted, or there is work pressure. So how do you work? We find ways of working around, and this is when an error happens. So what I want to do is, and I'm conscious of time, so what I want to do very quickly is, the person who sat, if I can ask you for the next, I'm going to show you a picture. Tell me quickly what's the difference between the two bags of fluid you're going to see. You literally have 10 seconds. Okay, ready? Okay. I asked you to look at it. The girl with the glasses. What is the difference? What is the difference between the two bags of fluid? Did you see it? Did you see it? Right. So, classic. What did I say? I'm going to show two bags of fluid. I said you have a look at it. So the rest of you switched off. You didn't focus on that. I mean, I did it for a purpose. It's not that I find it fault. Because he's the one who's been given the task. Okay? So he's been asked to look at the fluid. I'm not been asked to do it, so I'm not looking out for him. So what did you, can you tell us what was the difference? Correct. And what happens if you give the epidural bupivacaine intravenously? I mean, it's a stupid question, but still I'll ask. What happens if you give it intravenously? Yes, but what happens to the patient? Yes, it is not a theoretical question. What happens eventually to the patient? Patient dies. So this happened. We had a Filipino nurse who came, had a baby. 3 hours later, she was dead because they put the wrong fluid up. So these are all real cases. But what I'm trying to do here is to show you how distraction, because you were not involved in that particular exercise, you disconnected. Imagine he did not pick this up. You might have been able to pick it up. You were distracted, so you didn't look out for him. And he was in his own. If he hadn't picked it up, it would have been. So, distractions are constantly at play in our environment, but we have to look out for each other. Because each one of us, because if one day he will look out for you. So, this is another way of making sure you look at all my slides. Right, okay. No, but that's fine. I purposely said to distract you there. Okay. What do you see here? The girl with the yellow churidar, what can you see here? You have to speak up.
This is from anesthetist side.
Correct.
Waiting patient, all the infusions are being.
Correct. You know what we call this as? Blood-brain barrier. Brain this side, blood that side. But anyway, okay. So, looks complicated. How many infusion pumps can you see the girl next to you? Quick. 45. Oh, fine. Anything else you notice? Multiple IV things. Can you see the patient? Yeah. Okay. Sort of. Yeah. How many of you have been in a cardiac theatre, neuro theatre, massive whipples? Not unusual, right? No. So when you are in that situation, imagine you are sitting with your senior anesthetist. The senior anesthetist goes to for having a tea break. The technician is there, you will be left there. Okay? Everything is stable. Tell me what you will be doing. Monitor. Second, what else might you be doing? Okay. Alright, leave all that aside. Then give me the real answer. What will you be doing? Go on. Mobile. Instagram, WhatsApp, emails. What's the movie to go to? What will be your surgeon doing? Of course, he'll be operating, but what else might they be doing? Talking. Who will he be talking to? So a study was actually conducted to find out what are the interruptions in an average theatre. So this was done about 20 years ago. Mobile phone ringing 2 to 6 times, equipment issued 5 times, road opening 19 times, non-relevant conversation, constant. Now, in a matter of a few seconds, I gave him a task, distracted you, you missed that, bags. Imagine in an environment like this, with all this nonsense happening, how many more things we are missing? You know, the interesting thing is, you might be thinking in the back of your mind, oh my God, she's going on and on about this. Nothing happened. All our patients live. You know why? Because we made anesthesia a very safe specialty. The margin for error is massive. It's quite difficult to actually kill. So every day you're getting away with it. But one day you won't. And then you'll be headlines. Whether you're headlines or not, it will leave you with a trauma for the rest of your lives. Because I don't think any of us wake up in the morning to say we do, today how many people can I do harm? Unless you're somebody like Shipman in our country who killed a lot of people. But this is very, very important. What your content knowledge, absolutely, 100%. I have no doubt that you will all have content knowledge. What you do not have is the ability to manage your distractions. And you are a danger to your patients every day. Even worse, you don't even realize you're a danger to your patient. And today, I've got about 20, 30 people. Imagine how many more are sat outside without that knowledge. So your role is also to go out there and be people who can make a difference. So what I wanted to also, the picture I'm going to show you is this is the YouTube link for that case that I told you right at the start, the Martin robbery, Indian robbery, just a routine operation. Her husband has created it. I had the privilege of interacting with him on several times. And what amazed me was he never took the anesthetist or the ENT surgeon to task. He asked them to continue because he said, the two of you who now know what not knowing human factors training can do, but if you continue in your practice, you can make an impact and make a difference. So both of them went on to make a huge difference. In fact, after that, the government authorized money for simulation centers to be set up. Simulation then got embedded. So it is a complete transformation of the way we deliver healthcare. Now simulation is part of all our crisis management resource training. Although even now I feel we're not doing enough. So what I want to do is to end this presentation with a thought that I want you to remember. If you remember, I said about who's to blame, the student nurse this, that blame should go away. And most of you will think, well, what can I do? It's the organization. But you know where this blame culture comes from? Have a guess. Where does it start? Seniors. Where is? Come on, you're smiling, so you know the answer. Where else does it come from? Consultants. Anybody else? It starts from you. You know, I've done this exercise many times. I've said, imagine you're coming at 8 o'clock in the morning and somebody tells you on your morning shift, a patient had an anaphylactic reaction the previous day night. Somebody gave her penicillin even though they knew she had penicillin allergy. What will be your first question? Why? But before that, who did it? I mean, you're sitting here, you're asking me this, but I guarantee you, your first question is who did it? What relevance is it? Who did it? Is it what happened to the patient? What can I learn from it? So, the blame culture starts from each one of us. We want to find out who did it. So, unless we change, the blame mentality will change and will not change. And that is why today, when you see your colleagues making an error, or when you get asked a question in the debriefing and you don't ask an error, your response should not be, oh my God, you did not even know that, he did not even know that. No. Because you might be in the same situation, you might have done similarly. It's less about what they did, it's what you can learn from it. Okay. So that is why I talk about encouraging investigation and reporting mistakes. Okay. So I'll end with this thought. These are from Martin Browning himself. And human factors, he's defined human factors in a very easy way. And today we are going to find out how we can, each of us, become better at controlling the factors which influence the way we work. Being aware of how we behave in a stressful situation is a starting point. So we're going to provide you lots of opportunities to learn. Okay? Alright? Ready to get started? Alright. So before we get started, we have 4 scenarios and I need 10 volunteers to be part of the scenario. I will be distributing these 10 people across the 4 scenarios in any order, which I will not reveal to you right at the start. But I want these 10 people to be identified because what we're going to do is we're going to give you pre-briefing and we're going to show you how the environment where you work in is going to look like. Each one of you will be arriving in this operating theatre for the first time in your first day when you start working. And we will take you and show you what the operating theatre looks like for these 10 people so that when the scenario gets started, you know where you're going to be working. So, 10 volunteers. If you don't volunteer, then I will pick a few people. So, 10 volunteers. Please stand up so that I know and you can, so I need an equal distribution. So you're year 1.
This is.
Year 1. Year 2. Wonderful. So, okay. Let me have a few volunteers and then I know how to spread you out. Year 3. Wonderful. Year 1. Year 5.
The final year.
Oh, final year, right, okay.
She is here.
Year 2, right. Second year. So I have, if I can have
There was one
pairs.
intern who was so much interested, who was registered.
Ah, excellent, excellent. So if I can have the intern, if you can come here for a second, just because in my mind I need to know how to split you up. So you're going to be, if I can have a, do you have an obstetrician here?
Or OGPG.
Not in
Okay, that's fine, that's all right. So, so I have I'll have a year 1, please. Any year 1, you can just come and stand, then I know who else is left. There's a reason why I'm doing it in this order. So year 1, and I want a year 2. Any year 2s? Your year 2? Yes, please. Year 2. And I have another year 2. Right, marvelous. So you're going to be 1 group, okay? And you're going for the last scenario. So you've got 4 final years. So therefore, I need, standing, because then I need 3 year 1s or year 2s. Marvelous. So if you can just pick pairs, if I can ask for the first scenario, if I can have your year 1 and your year 3. So if you can just stand out so that you are the first scenario. The second scenario, if I can have yourself, please. And I will have two final years. Wonderful. Okay, please remember what you are because I forget. So your scenario. Okay.
I'm Aarti, I'm the staff nurse for today.
And Dr. Rupavani and the obstetrician.
Okay, right, over to you, sir.
Yeah. Good morning, everyone. Today you are going to manage a real-life crisis in obstetrics as a part of a simulation exercise. So, for the simulation exercise, there are some ground rules. The first ground rule is we'll take care of your psychological safety. So, you can afford to do mistakes, and we are not going to comment on you or laugh at you. Is it clear? You are free to do the mistakes. And we maintain confidentiality. So whatever happens in this room shall not go outside. Is that clear? Then, you need to enact the scenario realistically. Don't treat this as a doll. Is it okay? Perform the scenario close to realism. Then you need to respect 2 people here. One is the mannequin, treat it with some dignity. And second thing is respect your fellow participants. Then coming to the calling for help,
whatever you want will be given. So there are embedded participants here who have just now introduced. They'll help you to give whatever you want. Then the next thing is, there's something called Voice of God, where if some things are not available which you asked for, so it will be told that it is given, or some instructions will be given. Is it clear? So these are the ground rules. Next is about the you are there in this new setup. You need to get acquainted with this particular setup. So you have an anesthesia machine there, you have a monitor, you have a defibrillator, you have the crash cot, you have the difficult airway cot here. With regard to the measuring the blood pressure, the blood pressure is cycled every 5 minutes, and in between you want blood pressure, you say I want blood pressure, again the fresh cycle will come and new blood pressure is going to come. Is that clear? When you want the saturation, you need to connect the pulse oximeter probe. For ECG, you need to connect the ECG leads. And whenever in the scenario, if the scenario demands intubation, the confirmation of intubation is only the ETCO2 tracing, not that you have intubated. Please keep it in your mind. So that is about the monitor. Then with regard to the capabilities of the mannequin, this is a high fidelity mannequin where any difficult airway can be created. So you're going to feel a little tough when you are managing the airway. And the mannequin can talk. Heart sounds and lung sounds are possible. You can auscultate. With regard to these pulses, you can feel all the pulses. You can feel the carotid pulse, you can feel the brachial pulse, radial pulse and femoral pulse. Then with regard to the intervention, you can do all sorts of interventions which you can do it realistically. You can put the Ryle's tube, you can intubate, put up the supraglottic airway device, you can put up oropharyngeal airway, you can put up nasopharyngeal airway, you can do cricothyrotomy, you can put ICD, you can put Foley's catheter, all the things. So I introduced you to the SIM environment. All of you feel free to get used to the environment. Just feel the pulses, look at the monitors, just register in your brain what are the things that are available here before we go to the scenario. If you have any doubts, you can ask me. Any doubts? Nothing? Yeah, please get used to the setup. Come on, feel the pulses. And there are drugs here. All the drugs are loaded here. All the drugs are loaded here. So whenever you have to give the drugs, take the syringe. All the syringes are labeled and you can administer in the IV site. It is as if you are given the drug. Is that clear?
You can talk to the patient as well. So ask her her name, she will respond.
Yeah, talk to her.
What is your name? Okay, do you want to ask her her age? Just ask a couple of questions.
What is your age? What is
23. Do you have any medical problems? You know what you normally would ask. Do you have any asthma?
Do you have any comorbidity?
No.
Any medical agents?
I have sugar actually. and I take medicines for my fever currently.
Okay, alright. So you
And one more thing is be as loud as possible,
Yeah.
because whatever you are enacting here, it is going to be heard in the next room. Is it clear? Feel the pulses, get used to the machine, because this machine you are not used to. And here is the difficult airway. You have the visual laryngoscope, you have still left Buji, all the airways, ambu-back, everything you have here. And the drugs are there, laryngoscope, tubes. And realistically, you can put oxygen nitrous. Switch on the gas, please. Okay. Here is a defibrillator. Just get used to the defibrillator. Just switch it on.
Charging. Discharge button to the shop.
And there are a few drugs here. Come.
Left pad property. Red. Shop not delivered.
These are the drugs. All of you come here, get used to the drugs. Sudhakar? Sudhakar?
Can we get started?
Yes, yes. Okay, shall we start?
Yeah. Can we have you all back there? Yeah? Okay. All of you need to leave. Go back to your... Okay. So it is 8 o'clock in the night. It's a Sunday night. Okay. You just started your shift.
Okay.
Alright. And there is an emergency cesarean section. They want to take the... they took the patient already into theatre because you've just come on the shift. They couldn't wait for you to come and speak to the patient in the labor ward. So they've shifted the patient already into theatre because it's fetal distress. The name of the patient is Mrs. Gupta, and the obstetrician wants the baby to come out very quickly. So they want you to give a general anesthetic. Okay. So tell me if you can repeat the information I've given you.
Mrs. Gupta is taken up for emergency LSCS in view of fetal distress.
Yeah.
They wanted the delivery under general anesthesia.
Yes. So when you go in there, you will you'll behave exactly like what you would do in your own theatre. You will take a history, and then you will get preparation for a general anesthetic. As you know, they are all scrubbed up and waiting for you. Obstetrician is ready. You have the staff nurse, the circulatory nurse, the technician is also ready. And if you need anything, ask for it. Okay?
Intubation also I should do the
You should do it. You've done an intubation?
I have not done intubation in emergency LSCS, ma'am. I have given spinal.
You only given spinal. Okay, that's fine. So if you can't do it, then you need a senior, right?
Yes.
So once you go in there, when the time is ready, you need to ask for help. Okay? Right. Go ahead. Yeah.
I can talk to the patient.
She is conscious only. You have not yet anesthetized.
Oh, ma'am. Can I know your name?
Yes,
Your name, please?
Mrs. Gupta.
Is this your first pregnancy?
I can't hear you. Can you please be a little louder?
Is this your first pregnancy?
Yes.
Okay. Any previous surgeries?
No.
Any previous history of blood transfusions?
Are you new to this, OT? Which year are you?
I'm first year PG, anesthesia PG.
How can your senior send a first year PG for a distressed case? Fetal distress is there, fetal heart is dropping. Please intubate fast, no?
Doctor, is my baby going to die?
No.
Doctor?
Few minutes. You just give me the history. Any previous history of surgeries?
No.
Any previous blood transfusions?
No.
Okay. We can intubate the patient.
Am I going to die, doctor?
No. Can I have all the scopes are ready? 3 blade. Is the anesthesia machine checked?
Doctor, I'm so
All the emergency drugs are ready.
going to die.
Please do it fast, ma. Already you are late.
I'm so worried.
Tube ready. Is the airway cart ready? Keep 6.57 also get ready. Goodle's airway ready. Oral airway ready.
A fetal heart is 80. I don't want to lose the baby. I have to answer the attenders there. Please do it fast.
We'll pre-oxygenate the patient.
Okay, sir.
We'll do 100% oxygen. Pavitra, load.
Sir.
Load propofol.
Okay, sir.
I just don't want oxygen. It's so tight on my face. I feel really uncomfortable. Doctor, please. It's so tight. I feel so uncomfortable.
Doctor, please do it fast, no?
Okay.
Don't want this, doctor.
Sister, is the cleaning and draping over?
And is will my baby
I gave you
be
proper
okay?
fall, sir.
Give success. Can I get a unit?
Is my baby going to be okay, doctor?
It will be okay, ma'am.
Can I start? Can I do give the incision?
2 minutes, 2 minutes. Then you can respond. Can I get a sound size too?
7 size 2.
Shall I start now?
Yeah, tube in black markers, you can start the injection. Connect the ventilator. Pavitra, connect the ventilator. Keeps you, starts you. You can restart the injection. Start O2 on that. 3. You O2 on that.
It's not coming.
What happened now?
Everything's okay only.
Oh, why doesn't senior come inside, man? Why is a junior operator doing like this? Nurse, please call the senior doctor. Where is the senior anesthetist?
Everything's okay.
Vital stable,
Then
sir.
what's happening? Why is the saturation 81? I don't know. I'm going to deliver a dead-born baby or live baby now.
Patient's going for hypo. If this patient is getting research ready,
Call for help.
we'll call for help.
Why don't you call soon?
We'll give her.
Brother, can you call?
Can give a call somebody?
Please do it fast, ma.
Put it on that.
Please do it fast, please. What is happening to the patient? Oh God, the saturation is dropping.
Back.
Yeah, bag, ma. Bags.
Back fast. Give 6 meters auto. Back fast. Sir, we will BP. Sir, we use phenyl.
Where is the HOD? Where is the senior person?
Saturation is dropping, ma'am.
But you have put the tube in stomach or what?
Yes, sir.
close பண்ணு. Coming. ஓட்டு வச்சிருக்கேன். Once the saturation picks up, we'll intubate. Okay, it is picking up. Okay, now retry.
It's so bad, doctor. You should have come in the early stage itself. What is happening to the patient?
CMAC.
Sending junior people for a case like this. She's so sick. You people are playing with the patient. Have you got trained effectively or not?
Bag only, sir.
My God, almost 10 minutes over. What is happening here?
Auscultation.
Bring up the saturation. Bring up the saturation too much. Mark that was fast. So give another.
Somebody auscultate the fetal heart once.
Add 20 also.
You people don't understand. I have to answer the relatives outside. Something happens to the patient or baby, I am responsible. You will come and speak with me.
Buji.
Smaller size, what size?
6.5, ma'am. Auscultation.
What is happening here? Still the saturation is 69. What is happening to her, man?
Yes.
So LM is there. Okay.
Picked up.
Fast.
Can I start now?
Yes, ma'am, you start.
Okay.
As fast.
We'll stop the scenario now. So we'll ask the three of you to come out. Now these three people have had training for a failed intubation, they will never forget it for life. The rest of you have it. So remember that this is an opportunity for you to avail yourself whenever you have an opportunity to do it. Okay. So I think it's quite obvious. The scenario was what scenario? Failed. Right? Okay. And we spoke so much about failed intubation before we took you in. So it wasn't a surprise. You knew that today it was going to come. Right? So I asked you all the question, failed intubation drill. How many of you don't know about failed intubation drill? You all get given the protocol. What protocol do you follow for failed intubation? That's, or you have your own AOA as well. They also have come up with their own. Yeah. So the year ones. So you've been in anesthesia for 4 months. Have you been taught? Have you been taught the failed intubation drill? No. Right. Okay. So it's interesting because the number one emergency we have is failed intubation, and I'm not only you. My own first years, I worry because we don't teach them early enough, and we don't put them through it early enough. But anyway, right. That said, you did have help coming in quite quickly, so you were not left there on your own. Okay. So let me start by asking the people. So while you guys were going through it, these guys had something to do. I'm not quite sure whether they did it, but let us see whether they did. So on this side, we had a checklist for failed intubation. And on this side, you were given 2 documents. Alright? Forget the one with the color, the other document. And what was that document? Speak up. Today everybody should speak up, otherwise you're not going to have an opportunity to what is like failed intubation. Correct. Excellent. So you both have the answers with you. So what I'm going to do is I'm going to go through in a method by asking you to read the checklist and tell us whether it was done or not. And we're going to get your instruction. So let us start from the girl there. So what was the first line of that checklist?
Introduce self.
Excellent. So on this side, you watched what happened. Did she introduce herself? Okay. All right. Okay. Why is it that introducing yourself is relevant? Why do you introduce yourself to a patient? Absolutely, absolutely. Did she require any reassurance in this situation?
Yes.
Why does she require reassurance?
She's anxious.
Absolutely, it's an emergency situation, it's this and all that. So now comes the question where I want a truthful answer. Did she introduce herself or not? She didn't introduce herself. Did you introduce yourself? How many of you would have introduced yourself in that situation? That's, you had, okay, 2 people. With a little bit of experience and all those sort of things. So, a very simple point. So, you remember when I said about improving our relationship with patients? It starts from the first 5 seconds. Who are you? There are multiple people who are coming and talking. So, introducing yourself is very important. Okay, next step. Okay. So, this was a situation. This is a grade 1 cesarean section or a crash section as we call it. And pertinent obstetric history. So, what would be pertinent past medical history for obstetric history or whatever? What would be pertinent obstetric history? First pregnancy, comorbidities. How would you ask about comorbidities? Okay, all right. Because I generally find that you use patient unfriendly language. So that's the other thing I wanted to comment on, but then we will come to that. Okay. What else? Once again, before you go to that, some of you know, have the checklist. Is there anything else you can do to get some answers, quick answers, so that you can get all the information? Because information one way can come from the patient, another way can come from the case sheet. Okay, what's the other way? Yes, okay. So let us come to the obstetrician here. Alright? So what did you think about the obstetrician? Your thoughts? Helpful, unhelpful? Unhelpful. Right, okay. So is it, so what you saw portrayed there, is it an unusual presentation of an observation? So can you just say that a bit louder? Normal. Normal. This is a normal presentation. Ma'am? So we had this conversation yesterday because I've done this workshop for the last 15 years in different parts of India and in different languages. Except that, you know, the language changes. Sometimes you do Hindi, sometimes you do Malayalam, sometimes you do Telugu, whatever. But you know, consistently, I see the smile, the laughter from the anesthetist because finally they are seeing another person suffering like the way they have at the hands of an obstetrician.
One correction. It's normal for all other obstetricians, not for the
I know. Can we say a bit of a disclaimer? She's one of the nicest obstetricians apparently because she's married to an anesthetist. She's on our side. It was so difficult for me to make her do what she did. I had to act it out so many times yesterday. And she also said she was finding it peculiar. Why are you making me act like this? I mean, this is not. And I said, but that is normal. You're the abnormal. You see? But
he's the only obstetrician who ostentates the heart.
My God. She even gave some hints, the tube and this and that. I was thinking, who's this? You know, she's actually helping. So, in real life now, let's look at it another way. And I want you to, while this is to bring in an element of the stress and to bring in a little bit of laughs. You know, the first scenario, I want you to relax. And a more important question is, who are the year 3s here? Put your hands. Leave your hands up. Leave your hands up. How many of you have put your year 1s under stress when they have called you for it? If the answer is yes, leave your hands up. If the answer is no, put your hands down. So let me ask the question again. You feel uncomfortable in answering it, but that's the purpose of it. So while we are all looking at the obstetrician and saying, oh, terrible characters, they put us in our thing, as year 3s, you're no different with your year 1s. When they call you for help, you will first make them feel this tiny before you offer it. Not all of you, but some of you. So all I'm trying to say here is, managing a volatile situation with an unhelpful colleague is not necessarily from a different specialty, it's even from within your specialty, and each one of you could be displaying the behaviors that she displayed. Okay, right. So let us now ask ourselves the question, she's taking the history, you saw that it was being a difficult interaction, okay? She asked the comorbidities, we did all of that. There's one more thing that she needed to have done before she started the anesthesia. By the time you came in, right? Okay. So she called for help because she's not done any general anesthetic in emergency cesarean section. So let us ask you, you walked into the scenario. Did you know what the case was about? Because by the time, when you walked in, what and all was happening? Can you describe that for us?
She was trying to pre-oxidate the patient.
Okay.
That's it was obstetrician it's emergency.
Wanted you to get started.
Fetal distress, they want to start immediately. They told them want to
Do you know what the name of the patient was? Do you know what comorbidity she had? Okay. So let us, if I can test this out, sir, I just want to rewind to the point where he walked in. Sorry, what is your name? Gautam. When Gautam walked in, I just want to watch that entry point. Sure. Can we rewind it with your help? Yeah. No, he won't know where to rewind it to. It's Sunday evening.
Yes.
It's 8 o'clock. You've just started your shift.
Okay.
You took over from another colleague of yours.
Okay.
Who has done a spinal for this lady.
Okay. Okay.
Her name is Pooja.
I feel so cold and freezing.
You feel any pain?
No.
Can we check the saturation, please?
I can't
Pulse ox.
hear you. I feel so cold and so uncomfortable.
You feel any pain?
No,
I'll just check the level for spinal anesthesia. You feel pain any
no,
in here?
no,
This area?
no.
No pain. Okay. Just a minute, ma'am.
But I'm really not okay.
Can we connect the oxygen, please? Ma'am, call for help.
Yeah.
How are you feeling now, Pooja?
Not okay, I'm not feeling right.
She's actually not bleeding that much.
Okay, okay, ma'am.
Only some retained bits are there.
18 beats.
I don't know why this hypotension is happening.
I suspect the spinal have been regressed, sir. Spinal have been already given, sir, the last shift. Now the patient is complaining of coldness, sir, and saturation is dropping, and she has also
Investigation normal?
yes, sir, normal, sir. Already spinal has been given.
She's
So
fine actually suddenly she had a syncopal attack.
Spinal is given?
yes, sir, spinal already administered, and
Yeah, syncopal attack.
I have checked the spinal levels also.
Only some retained bits are there. She was in labor for 3 days. She had leaking for 24 hours. But otherwise, she
Yes, sir, oxygen kept, sir.
Doctor, I want to go.
Dose, I don't know, sir. Previously they have administered, and I also checked the level, sir. It's adequate. Patient is not feeling any pain.
Doctor, I feel like I want to go home.
Okay, please calm down.
uterus also
okay?
seems to be well
I'm so tired, I'm not okay, doctor.
Baby is
Delivered, sir.
delivered 2 days
For
back, sir.
manual removal of placenta, sir.
She had leaking for 24 hours. Otherwise, everything was fine. Placenta also was removed, but I think some retained bits were there. That also has
Now,
removed.
spinal is given for how long? Duration of surgery?
Duration, I don't know, sir. The last shift they have given, sir. I've just taken over. Sir, I didn't administer, sir. Previously they have given. I've just checked the spinal level also. It's adequate.
Doctor, I'm scared, I want to go home.
Take Loxicart.
Loxicart. Loxicart.
Doctor, I can see some rash on the thigh. I don't know how it is happening.
Okay, given 4 ml of Loxicart.
4 ml of Loxicart.
Okay.
Given, sir.
Comos history?
No comop, sir.
Okay, I'd like to call for help. Calling for help. I want to remove this and connect on. Okay, take this supply.
I'm putting the bag, sir.
No other comos, right?
I didn't know about the allergic history, sir. I didn't ask her. No, sir.
Are you okay? Please talk to me.
No, I'm not.
Are you in any pain? Any distress? What's your name? Please tell me your name.
Patient not responding.
Are you okay? Ma'am? Please tell me your name.
Patient, they underwent spinal procedure over. Parents was on rash and desaturation and patient is not breathing. And not responding to social. Responding before, now she's not responding.
Ma'am, please tell me your name. Are you
Ma'am, I
okay?
checked the saturation is dropping and she also having tachycardia, ma'am. I've checked the spinal level also. It's adequate. Patient is not feeling any pain, but she's complaining of coldness, extremities.
I've given Loxicart 4 ml. to settle the tachycardia, but she's desaturating now. I think we have to intubate the patient. She's not responding.
Start oxygenating and secure the airway.
Please flush fluid in the place.
What is the BP?
70. BP is dropping.
BP,
Give MEF 167.
MEF
1 ml
6 mg given, sir. Phenylephrine.
Give 2 cc.
With rapid CC.
Yeah, take sucks. Propofol sucks up.
Propofol and Saxa. Propofol.
Is BP picking up?
Slowly.
Swallow.
Pressure.
Okay.
Okay. Intubating the patient. Able to visualize?
And pulse volume good, ma'am.
Tubal?
Tubal. Please auscultate.
Auscultation. Yes, sir. Bag, ma'am. Tube in, ma'am.
Can I start?
Can you rush the fluids?
Fluid rush.
Can you brush the fluids and give one more?
Yes, I have removed the placental bits. Uterus is also well contracted. Is she sick?
Pulse is good, ma'am. Blood loss.
Blood loss is very minimal. Probably around some 50 ml, not more than that.
Shall we give phenylephrine? Phenylephrine 50 mics, 1 cc.
Another rash is there on this side. What's happening? She is having developing allergic reaction, something like that.
No, sir.
Had before.
Maybe anaphylactic reaction she's having.
Sir, last.
Okay, we can give. We'll give steroid. BP is still not picking up. Please rush another.
Sir, the patient was already administered.
I mean, allergy.
I didn't know, ma'am. I didn't get the history from the patient.
She developed rash. When I came, the saturation, tachycardia was here, desaturation, and BP was falling. So the patient was responding, but when I came now, patient not responding at all.
She complains of coldness, ma'am, but she didn't complain of pain, any. Blood loss is minimal, ma'am.
BP not picking up. Tachy, I've given oxygen.
Maybe after the crash.
Probably little bit she had bled before shifting here. Maybe it is because of latent placenta. Should we intubate and we should shift to the ICU?
We have already intubated.
They'll shift the.
No, because the procedure is finished. Should we keep her on ventilator in the ICU for some more time?
If is not picking up and she's needing more support, we can shift her to
I think it is probably anaphylactic reaction, so we keep her intubated for some time.
and observe.
Yeah,
For anaphylactic reaction to settle up.
Can you give one more bolus of
Because we'll stop
Adrenaline.
Madam, do you think she's improving? Or, should we explain to the attender what's happening? Like, because when I was shifting, husband was not there to take the consent. So I had to shift her in an emergency. So I need to explain to the attendant. Can you please come along with me to explain to the attendant? Yes. You please take care of the patient.
Fluid dish. Yes, sir.
We had to, because you were not there, we tried to contact you over phone, but your phone was switched off.
I was here half an hour back only, but you haven't told me anything about that. And
Probably.
what is that retained placenta? What is that?
It is something which gives the blood supply to the baby, and it will come out immediately after the delivery.
You should only take it out now.
Yeah, it has come out. So we presume that it has come out completely. But I think there were some bits which were there inside. That's why she would have bled. Okay. So that is the reason. But don't worry. Now everything is removed and she is absolutely fine. Now her uterus is contracted. She is not bleeding that much. But actually she is in theatre. And doctor only has taken care of her. She is an anesthetist, okay, and she had intubated her, and she feels that she needs little more ventilation.
So currently she's having hypotension. Her BP is not picking up, and she's having rashes all over her body because of after this. So we'll have to further evaluate her why her rashes are there, and her BP should pick up. So
No, actually half an hour back she was fine only. When I went out, see, I left her. See, I thought you people will take care of her, but suddenly after half an hour, when I came back, you say she's in ICU. What has happened to her? Immediately, I mean, suddenly what has happened to her?
now, as of now, she's fine. So we have obstetrician. They have removed the placenta fully, and now her BP is not picking up. That is our only concern now. And then we cannot extubate her with this condition. So we'll have to monitor her.
What is meant by extubation?
Now we have intubated her. And
What
we
is
have
intubation?
Intubation. We have put an tube in her airways, sir, so that she's being ventilated through a machine. She's not taking own breath.
You have put her on a ventilator?
Yes, sir. Yes. You don't have to panic for this because this has to be done. Because
will she come back?
Yes, definitely. But it takes time.
How much time?
Patience, sir.
See, half an hour back I have seen her alive, but now you say she's in ventilator and all those things and all. How come? Is that a part of mismanagement or something?
No, so we are trying our best to help you out here. No, don't worry. We'll be shifting her to the ICU and we'll take maximum care and we will make sure she's okay.
No, I don't believe you people because half an hour back I saw her fine. You are telling that she's on the ventilator control, support, all those things and all. I'm panicked. What is it? Will you give my wife back?
So we'll try our best, sir. We'll do what needs to be done. But now, as of now, we'll be shifting her to the ICU and her BP has to pick up. We'll have to start her with some supports for her BP to pick up and she needs to be ventilated, sir.
I don't believe in you people, sir. Can you call someone higher up because I have to talk to the management or else you will face the consequences.
Sir, we'll manage. You wait. She'll be okay, sir. We'll let you know.
You said I saw her talking to me, but now she's not able to talk. Also, she's with that tube in her mouth. What is the problem with her? You have done something wrong. You have mismanaged her. See, I'm going to really sue you in court. Where is the management people?
Sir, I'll let them know and they'll come and talk to you.
I want the management people to come and talk to me.
Management people are never there. management side, and I know what my consultants tell me. You're never there when we need you. So yes, sorry. Anyway, wonderful. Where are the three people? Round of applause. Sit down. So this is a different type of a scenario for you all.
Madam, you have mic, madam. Yes, madam.
Oh, okay. You're not able to hear me in the back?
Here, but still.
Oh, I find it difficult to hold it, but I will. Yeah, okay. So this is a different type of a scenario because I wanted you to live the entire journey. Very rarely do we get the opportunity to live the whole journey in a simulated environment. So today is your opportunity. So can I start with the first person who was there? Yes. What was it? What did it feel like being part of this experience?
Decision making also.
Okay. Yeah. So you can say that. Yeah.
I couldn't think clearly. That is.
Right. Okay. Your first year? Okay. So for people who know him, do you think he's somebody who's not capable of making decisions? Oh, he's not capable of making decisions. I thought. Okay. How was it? Second person in. Yes. How was it for you?
For me, it was. I also couldn't think clearly. Being a manager, what exactly to be done, management and all that.
Yes. So your name is?
Dr. Anu.
Anu. So is Dr. Anu the person who's not capable of making decisions? He is capable. Right. Who is the third person? And you know what I want to ask. Okay. What is your, how did you feel going in there?
I had to take care of the agitating circulation, but then my main concern was...
No, what was your, just your, I'm just looking, wanting to know your feelings. What was your feelings?
I had difficulty with explaining everything.
Okay, right. So what I'm trying to say here is, none of us are incapable. Okay? We are all highly educated, highly skilled, and yet we find it difficult when we are faced in that situation. It happens to everyone. Okay? So because it happens to everyone, it's all the more important for us to get prepared for this sort of a situation. That is why you're here today. Alright? So did you find that exercise useful? It's a leading question. You can only say one thing, yes. Okay, fine. I want to start in the reverse order. Okay? I want to dissect it out from the last thing that you saw. So here is an husband and there's an interaction with the anesthetist and the obstetrician. So just open up comments. Tell me all the things that you saw, anything that you wanted to... first of all, can I ask you, do you speak to relatives? Yeah, all the time. Do you find yourself in a situation where relatives can be slightly aggressive? Do you think you're good communicators? Yes, no. Average. Average. But how do you know you're average? Has anybody scored you average? So it comes back to, see, I'm a salesperson here. I'm selling simulation to you. I want each one of you to go and torture your management to say that we want more simulation, because nobody has watched you communicate. You think you're average because you're very kind and giving yourself average. Some of you might be thinking I'm fantastic. Some of you might think I'm fantastic. But is that really the case? Only by experience, right? So let us now pick up all the things that happened in that interaction. So we are going to replay back only the interaction. Man, yeah, the interaction between the relative and yourself. So just from that, after I want to finish off the obstetrician bit.
You don't know when they will be more aggressive.
Very unpredictable.
Yeah.
Because in their situation, they are afraid. Their fear comes out as antagonism. Yeah. So we have to be sympathetic to them as well. Yeah. Okay. What else?
Here most often they come as a crowd. They don't come as a single person.
True.
Most often it will be
Absolutely.
the whole village will be there also.
Absolutely. Absolutely. And also you will be left on your own. So I'd asked the obstetrician to leave and go because I wanted you to be feel that pressure. So suddenly she left. That's what happens, isn't it?
We always say that the patient is fine, madam.
Yeah, exactly. Okay, so I wanted you to have another round of sort of an interaction with the husband, but I'm just conscious of time. So we might do it at the end. Let's see if we have time. Okay, so now I'm going to play back. So what are we playing back now? She is 28 years old. It is 10 o'clock in the night. Okay, and you have taken a patient, Handa baby, into theatre. She's got an epidural in place, epidural catheter in place, and you have topped it up with 20 mils of, what do you normally give for top up? We give 0.5% bupropion, or we give 2% lidocaine with adrenaline,
Yes.
with fentanyl. What do you?
BP again 0.15% or 0.25%.
Okay, so your usual top up you've given, and you've the epidural top up was given. The trainee who gave the top up has moved the patient into theatre because you were busy with another epidural, and they have now been called to do an epidural in another room. So they've left you with this Handa baby. She's 28 years old. She doesn't speak much English, but if you talk to her, she will speak. And epidural was working, the block was working very well, so they were told by the obstetrician that she can continue. It's grade 2 cesarean section. So you've come right at the start. Everything is scrubbed up and all that, and they're getting ready. You have just been introduced to the patient. You have not yet told her who you are, and you can get started from that. So this is an epidural top-up for a cesarean section. Can you repeat the information?
Yeah, 28 years of female, Hannah BB.
Yeah.
Epidural was secured earlier and patient was shifted in, and they have informed me regarding that. I have just now come inside.
Yes.
Patient is posted for cesarean section.
Yes, she's been given the top-up.
You on the top up.
The block is working.
Block is working, ma'am.
So they can start the cesarean section.
Okay.
Yeah?
Sure.
Agree?
Yeah. Can I start? Hello, I'm Dr. Jayavikasan, your anesthetist now. Can you tell me your name?
Handa baby.
Okay. Is there any pain?
No.
Okay. Is the pulse house functioning? Can you connect with all the monitors, please? Is there any discomfort for you?
No.
Okay. And we'll start the procedure when the BP comes, ma'am. Yeah, I can start the procedure, ma'am.
I'm starting.
Yes, ma'am. Yeah, what is happening? What is happening? Is there any issue with you? Ma'am, Hannah baby, are you there? Patient is Okay, can you give the mask? Call for help. Six liters of water. Ma'am, patient Hannah Bibi, she was posted for LSCS. Epidural was given earlier. Top-up was also given. Patient didn't have any complaints when the surgery started. Post-surgery, patient developed saturation drop and the pulse has increased to 160 and the BP was also raised, ma'am. I can't. Yeah, top-up was given earlier before the surgery itself, but block was working. Yeah. Yeah, only on epidural.
Is she responsive?
No, she is not responsive, ma'am. No, not settling, ma'am. And I have kept on 6 liters of O2 in, I have mask ventilating, ma'am. Still the saturation is in 86, ma'am.
She has had a GTCS.
Yeah, yes, ma'am. There was an episode of seizures when just post that patient was not responding, ma'am.
And post the seizure, she's not responsive, right?
Yeah.
And the tachycardia after that.
Yeah, post seizures tachycardia was there and saturation drop was there.
The airway card, everything is ready.
Yeah, everything is steady, ma'am.
Can I have the O2 is there? Okay.
Yes. Suction, please.
Scope and tube.
Put it in bag mode.
She is not a normal case of preeclampsia. Her BP was always normal. Like seizure we have occurred in this patient.
The BP prior to the...
It was fine, ma'am.
Normal. Always not more than 120/80. BP was always normal. It was 120/80. That's all.
Yes, ma'am, I will ventilate, ma'am. Tube in, ma'am. Equal. I can I try this tube, sir? Can you check where the rail strip is? Tube.
Put it on ventilator.
It's an ventilator.
Put it on back.
Yes, ma'am, was in position.
Check the main.
can check for carotid pulse, ma'am.
Is the flow there? His heart rate is there.
Carotid pulse, can you check for carotid pulse, ma'am? Can you start CP? I'll start CP.
So the patient had a seizure. After seizure, the patient had an epidural top applied and caused the epidural top during the seizure. And patient had hypertension and was hurt.
Yes, ma'am. Prior to the surgery.
Whatever drugs we have given the antibiotics.
Pulse not film. Continuing CPR. Can we have a 5, 6, 7, 8, 9, 10?
Let's stop it. In these sort of situations. And where we most want the human brain to help, if you have a conversation there, it's distracting for people in front. So just please. So where you most want your brain to work, that is when it shuts down. Yeah? So this mind fog, brain fog we call it as. Interestingly, the term brain fog apparently is associated with menopause. And they blame it on women that we have brain fog. But I like to say that we all have brain fog when we are placed in a critical situation. Right. So for some of you sitting in this room, you know what the answer is. And it's not a question of answer. It is getting to that point of making that differential diagnosis. So let us start with the things that you did very well. Can we play right at the start? Sir.
Confirm whether it's a flat line by checking the leads.
Yes.
Then
Enhance the sensitivity. Yes. So I'm not, sir is not in the test here. What I was trying to tell him was, sir is the expert in this. Your trainees are not answering me, so please ask them to answer me is what I was trying to say. Okay.
Take fibrillation. Early defibrillation.
For asystole, we don't know.
After cardiac arrest.
Yes, but for asystole, it's not advised. But nevertheless, okay. What else would you do in start CPR? Yeah, what you did. And would you do? You said 2 breaths, but especially as intubated. All I'm saying is, it's just an demonstration of the fact that you know theory, and yet you're not applying it there. Because you don't get a patient neatly in cardiac arrest and in front of you to say, right, you have this person will do compressions, that person will do airway, and then we can do it. Like the way you get taught when you're first learning about algorithms. In life, it never happens that way. There is the confusion about the diagnosis. There are conflicting signs. I mean, your obstetrician was such a lovely person. Imagine you had the obstetrician also being anxious and coming into this and saying, I want to help, what's going on, what's happening to my patient. So you have an imperfect world when you have to do or deliver the knowledge that you have. The problem is you get taught your knowledge in a perfect world, but then you're asked to deliver it when it is imperfect. So the question I have for you is, asystole amongst the resuscitation algorithms is the easiest to do. Because there's hardly anything you can do other than cardiac compressions and thinking of a differential diagnosis. All you have to do is keep doing the cardiac compressions and go through a list of differential diagnoses. Wonderful. What are the 5 H's and 5 T's since you opened your mouth, you have to answer? Yes. Right. not an exercise. So simulation is, so when I do my simulations, I'm not going to give you an MCQ, I'm not going to ask you for content knowledge. It is worth all of you answering it and coming up collectively with the answer. But remember that content knowledge has to be, you wake up in the middle of the night, you have to have it at the tips of your fingers. There is no other option of doing it. Now, one of my responses to that content knowledge is completely different. Your seniors may or may not agree to this, but I'm going to say it. What I say to my trainees is, you might have the best content knowledge, you're not going to remember it, even if it's in the tip of your fingers. There is another way of accessing that information. And what is that? Every theatre should have a, what will you have? Yes, and where is your algorithm? So in your theatre, where is your algorithm? Your resuscitation algorithm. In your own theatre, in your own hospital.
It's just behind it's hidden of the.
In every theatre is there behind? That's all. So don't, for heaven's sake, don't use your lovely brains. It doesn't work. Look at the algorithm. Right. Now, if you look at the algorithm, he would have been looking at the algorithm, she would have been looking at the algorithm, somebody else will be looking at the algorithm. What's the best way of following the algorithm? You watching it and doing it? Or somebody else reading it? Who would have been that somebody else? In fact, can you just switch on the camera feed and show me for a second, please? For instance, one of the things we say is sterile cockpit. So you know when the plane lands and takes off, there will be no conversations during taking off. The equivalent for us is intubation and extubation. No talking. So how many of you do not talk or have any conversations when you are intubated? Really? Maybe only two. Everybody, all of us, the rest of us talk. Who do you talk to? Seniors, consultants, technicians. You're obviously talking very important things. Are you? You don't talk about what happened yesterday, how the next patient, when you have to get them in, there's too many cases on the list. The surgeon is too slow. Why am I doing this case? Why was I assigned this list? I shouldn't actually be here today. I wanted to leave. This case is going to overrun. So, what I'm trying to say is, because we do these things repeatedly, we assume that we can do it without, people will say this, I can do this with my eyes shut. That's the other thing. So, the thing what I'm trying to say here is the discipline of accepting that these are critical moments. The intubation itself is like this. Imagine extubation. Everybody is around you talking, distracting you, the next patient is coming in. But you've got to get into the discipline of not interrupting, because you're not the only person who gets interrupted. Many times you're the one who's interrupting your colleague. That 30 seconds when they're intubating, you won't stop. Only at that time you'll want to come and say something totally important or unimportant. So it's about having that emotional discipline that during crucial moments, irrespective of how many times you've done it, whether you put in the cart line, you put the central line, you intubate, whatever, you have the discipline of focusing on one. So it's that all of those things contribute to the human factors approach. Because when you follow that, others will follow it. And then if you remember what I said about the lining up of the holes, when you contribute to that safety environment, then when next time you have a problem, others will also be quiet because they know that this is a crucial element. And they help you to arrive at the right diagnosis. Okay. Convulsions, differential diagnosis. Apart from eclampsia, what are the differential diagnoses? These guys know the diagnosis. What are your other differential diagnoses for eclampsia other than pre-eclampsia? I know you've seen it now. Okay, right. Okay. So local anesthetic toxicity, extremely rare. Yeah? Has anyone seen it?
Yes.
Ah, right. Can you share with us?
When I was a senior resident in EMC, inside in local procedure they are in centroplasty.
Right.
There they usually use buprenorphine and lipo area and they inject their receptor.
Right.
So there we checked no patient used to have tachycardia.
Right.
Then after some surgery became
Right.
And by the time we were shifting to ICU, we had seizures.
Right.
So then we were running for it. Literally, we were asking where,
Right.
calling each and every place.
Right.
Finally, it was in OG ICU. And
Right.
then we brought from another block.
Right.
And then, but it was a wonder. When you gave within 9 minutes,
It's magic.
And 2 hours we had executed the case.
See? Yeah. So, but that high index of suspicion you need to have. So I'll just come back to that, to the differential diagnosis second. Can I just ask, where is intralipid in your theatres? Locked up somewhere. Sorry? I can't hear what you said. So his question is that intralipid content is in propofol, so you can give propofol as the treatment for local anesthetic toxicity. Oh, no, where is intralipid stored is where what I was asking. Where? There. Okay, which you're NGM, right? Okay. The other one is Indira Gandhi. There's nobody from Indira Gandhi or the other hospital? Yes, where is it available in your main OT? Where? Which cupboard? Which theatre? Okay. Why I ask you is that, like what he said, if you cannot look for it in an emergency, there are certain things you should always know where it is. Failed intubation trolley. Where is your failed intubation trolley kept? Where's your failed intubation trolley kept? And then, of every theatre? Okay, so we have only one failed intubation trolley with the video laryngoscope, everything, which is kept in the middle of our long corridor, and it is signposted in every theatre where to find it. Where is your resus trolley kept? Come on, you should know that. Where is it kept? Which corridor? Where in the corridor? Anybody else? In your own hospital, so where is the closest research trolley to you? Right, okay. All I'm doing this is as a demonstration, station trolley. Just simple things. The situation didn't happen to me, it happened to a colleague. It was talked up by somebody else, and it was working epidural during labor. And then this happened. So there were various theories given to it, but if you read the literature, they say that the epidural catheter can wander at any time. When you're aspirating, many times I find that you don't actually aspirate properly because you don't use a 2 ml syringe, you use a 10 ml syringe, you use a 20 ml syringe, you do a half-hearted aspiration, and then there is blood in the catheter, but it is behind the dressing, you don't see it, you inject it. One hole might be sitting in the blood vessel, another hole might be sitting out. You don't know. But unless you have a high index of suspicion, there's no harm in giving intravenous. So convulsions, local anesthetic toxicity, preeclampsia, anything else? I don't think, yeah. The neurological causes. I mean, there's so many case reports of all sorts of things that they talk about. Extradural hematomas. There is an issue with what is that thing with your obstetricians? You talk about it, isn't it? That yes, yeah. There's another one. What is press? Now the press is got. Now everything is press. So yeah. So you have a list of differential diagnoses, and you go in a methodological manner, rule out everything. Actually, mostly symptomatic treatment, except for local anesthetic toxicity, where it has to be internal. Okay, right. I'm sure you're all starving. Anything else I missed, sir, ma'am, you want to add? Ma'am?
Final last consultant who is coming, specialist should ask. But then yeah, and they should lead. They should not enter into that scenario and do perform, as you said. They should not perform.
Yes. Yeah.
Like ACLS thing, they have to be the team leader, and then they have to just analyze the situation and just give orders.
Absolutely. Okay.
And they can go further for some investigations.
Yes. Yeah.
Of differential diagnosis. Unless they put out the differential
Yes.
diagnosis, they cannot complete that.
Absolutely.
Unless we know the diagnosis, we cannot treat the patient. Here the main problem was they couldn't come to a conclusion or diagnose the cause. So
Yes.
only they were not sure what to do next.
Yeah.
So that is the problem.
And the scenario was playing out ahead of them rather than them controlling the scenario. So what I thought was, I'm going to ask you to come up with 3 learning outcomes. But for this, the last scenario post-lunch, I want you all to consider everything that you've learned. Okay? So let's just capture the learning from this scenario. So 3 things that you've learned. Can you share? First. Anybody?
That needs to be a leader and lead the scenario and not
the doing. So leading, not doing. Okay, very good. That's a clear learning outcome. Second, let's ask, are you all 3 obstetricians? Okay, but you can still have some learning from this. So do you want to share something that you've learned from what we've said? Okay, we'll come back to you. Right, anything, yeah. Yes.
Designate roles.
Designate roles. Okay, right? Very good. So that everybody knows what they do. So let's reading, let's doing, designate roles. Third. Vocalize the differential diagnosis. So these 3 things I want you to remember. So the people who are going for the last scenario, I want you to think of these things. When you appoint a leader, make sure that leader is leading, not doing. Make sure that the leader assigns roles so that there is a clarity of what everybody is doing. And third is when you're going through differential diagnosis, vocalize it. So this should be the leader who should be vocalizing it, or whoever comes first or second or whatever, so that everybody else is on the same page, so that they can correct if you have any misconceptions, or they can go down the road route that you are asking them to go down, so that you're clear on how you're helping. Okay? So we're going to do that post-lunch, and I want it to be the perfect scenario so that when you leave here, you know how to do things. Okay? Is it helpful? Good. Is it time for lunch now? Yes, for lunch.
She is 32 years old. This is her first baby. And it's emergency crash cesarean section. The obstetrician wants general anesthetic because it is fetal distress. Okay, that's the information. They've shifted the patient to the theatre because they don't want to waste time.
Okay.
So obstetrician is ready. You have your technician, you have your scrubbers and your circulating nurse.
Okay.
So can you repeat what we discussed?
32-year-old female, Meera, primary, posted for emergency LSES in view of fetal distress under GA. Okay. Start. Start. I'm starting. Do you start? Start. What is your name? Meera, this is Nina. I'll be your anesthetist for today. We will be giving you general anesthesia. Before that, I would like to know if you have any previous surgeries done? Any allergic history? No. Any comorbidities like diabetes, hypertension?
You are speaking with the patient. You already know regarding the case. You already have given the details. Please intubate fast.
5 minutes, just basic information. Connect the monitors. Your baby will be fine as soon as you get into the surgery. Give me 5 minutes. Huh?
Am I going to die then?
No, it'll be all right. 1 second. Monitors connect பண்ணுங்க. ECG, pulse ox, BP connect பண்ணுங்க. Propofol. What is propofol? Sure.
come early.
My baby going to die.
Your baby will be all right. You just take normal breaths in this. Brother, carotid pressure கொடுக்கணும். Post ventilation. Drugs கொடுத்துட்டீங்களா? BP இன்னும் வரல.
Can I start?
One minute. BP press. Blood pressure.
The mask is very tight, doctor.
Just for 5 minutes. Take normal breath.
No, it's very uncomfortable. I don't want it. It's very tight for me.
Just bear for 5 minutes. You'll be all right. And propofol, Midas propofol, Saxa. Blood pressure is still not seen. Brother, check.
Doctor, fetal heart was 80. That's why I asked for general anesthesia. It's taking so long.
Just 5 minutes, ma'am.
Why doesn't the senior come into the picture?
Call for help, ma'am.
Please call some senior inside. Why do they leave juniors for such a sick case?
Okay, brother, scope konu. Brother, tube போட்டுக்கோங்க ஆஸ்கல்டேட் பண்ணுங்க.
What is happening, ma? Nobody has come inside. What are you doing, pa?
Ma'am, I'm finding it difficult to wait, one thing. ETCO2 curve is not there, ma'am. Chest rise present. Mask ventilate பண்ணிக்கணும்.
What is the problem, doctor? Again, you have removed the tube.
Ma'am, the ETCO2 curve is not come, ma'am. I think we're not able to ventilate. Called for help. Nobody's here yet. Ventilate பண்ணிக்கோ. Ma'am, this is a 32-year-old female, primary, posted for emergency and LSCS, ma'am.
Inside, doctor. See how she is dressing. You are leaving a junior.
I'm assessing the situation. Just give me some time. Tell me what happened quickly.
Ma'am, 32-year-old female, primary, posted for emergency LSCS, no allergic history, no other comorbidities, ma'am. We tried securing the airway once. Patient was still desaturating, ma'am. Section. Ma'am, I wanted to take over the airway, ma'am.
Secure the airway.
Yes, ma'am.
Okay. Any other issues I should be concerned about?
No, ma'am. Otherwise, the vitals are stable except for the desaturation. Given, ma'am.
How many attempts have you made?
I've attempted once, ma'am.
Ventilate பண்ணுங்க. Scope la வெயிட் பண்ணுங்க. Relaxant கொடுத்தாச்சுல?
Yes, ma'am.
நீங்க record கொடுங்க. கம்மியா. Scope கொடுங்க brother. Okay, I'm basically not able to see the epiglottis.
I'm saturation is 83.
CL grade 4. I don't think I'll be able to intubate even with
Where is the HOD, ma'am? There is a senior person here. She is not able to see.
Okay.
How she'll intubate?
ஐஜல் எதா இருக்கா? ஐஜல் ரெடி பண்ணுங்க. ரெடியா? Open the airway.
Back ventilate back.
Ventilate. DTCO is coming.
It is to come.
Ma'am, you can proceed.
Yeah, thank you.
Secure the airway.
Okay, we stop the scenario, we will go out. Do about managing the observation. Communicated once. She did another thing which is quite interesting as well. She said she'd take 5 minutes, so she asked her to keep quiet for 5 minutes. In a very polite way. There was no anger or anything there. But she put her in a place, but gave her a reason for putting her in a place. Okay? And then she took the history. What are the one thing which I hoped you would do, but you didn't do? Airway okay? Monitor, no, one more. The one that I was telling you about, which killed the patient. What she should have done after taking history and the airway and everything else. Machine check. Yeah, machine check. Yeah, that. Do remember that. It doesn't take long, but it's okay, right. And then after that, you gave your induction agent. So you did rapid sequence induction. Sort of. So what was missing in a rapid sequence induction? Right blood pressure. You seem to forget that though. I don't know why. Anyway, fine. So you put it in. How many attempts did you take? How many attempts did she take? Correct. And what did she do after that? Correct. Efficiently done. Now, you were in there this time. What was your tachycardia this time compared to last time? Yes. Because, what was the difference between last time and this time? Correct. So, for us to feel calm about a fair intubation scenario, we've experienced it once. We feel better the second time, we feel better the third time, we feel better the fourth time. Imagine if you had to have it in real life. It would be awful. You don't want to have it in real life to feel comfortable when you have it the next time. So, repeatedly doing it in simulation, absolutely calm and prepared. So, that's another useful thing. Straight away called for help. Then, help arrived. So, you had your handover. Somebody already said she gave a good handover. Why did you think, so what were the components of the handover? What did she do correctly about the handover? Yeah, background. And what was the recommendation? Yes, in fact, she said it, but in her case, when you came, you actually asked her, what do you want me to do? You want me to take care of the airway? So there was a two-way communication, confirmation, that's the only thing. And she asked something very interesting to clarify. Is there anything else I need to know about this patient that I need to be worried about? So in that case, she covered that. And then when you took over, what happened? What did she do when she took over? In terms of the airway itself. What did she do? Correct. So, role assigning, task assigning, a clear direction of what she was going to do. And then when she looked in, what did she say? So she did something called vocalizing. So everybody in that theatre knew what she was having, a problem, and what else they told. She not only told them the problem, she also told them what she was going to. She told the problem, and what else did she say at the same time? Correct. She also gave a solution. She said, I'm not going to be able to do it, so I'm going to go for an alternate airway, 9J. And she did that. So, the whole sequence of steps didn't take that long. And what was the environment inside? Chaotic? Was it chaotic? You're not sure whether it's yes or no. So, compare it to what it was in the first scenario. Which was chaotic? Exactly. This was controlled Well, you could say chaotic, it's always chaotic, but there's a lot of control in this when compared to the other. Yeah? So the purpose of repeating the scenario was to show you that given a little bit of practice, and I didn't want to do it straight away, give a little bit of gap, you've done the other scenarios, you know what can be done, what can't be done. So it gives you the confidence that given a little bit of time and practice, you can do it perfectly. And now, if you were, God forbid you to have that same problem tonight or tomorrow night or whatever, you will be far more experienced and confident in what you're going to do than what you felt first thing in the morning. Okay? Happy? Wonderful. So thank you very much both of you for doing it, for you doing it first time and for you doing it second time. Okay? Right. So we're going to go to our last scenario. And the last scenario is I've got 4 people. Plus, I've got my 3 obstetricians who are obstetric trainees. They're all going to be part of it. You'll be delighted to know. So, where are the 4 people? Yes, yeah.
She's not responding. What was her name? What was history? What was the history? ಇದು ಮಾನಿಟರ್ ಆಕಾಶವಾಣಿ ಅಮ್ಮ ಫ್ಲೂಟ್ ಆಗಿ ಟೈಮ್ ಫ್ಲೂಟ್ ಐ ವಿಲ್ have a time. Okay, fluid is going on. Come here. What was the history actually? Staffness. Staffness. Intern. Can you tell the history now? Monitor आकाशवाणी. Brother fluid response. I can't feel any SP or the probe?
Ma'am, patient name is Ruby. She's 36 years old. She's a multi-para. She's been induced and there is no time for epidural, ma'am. And suddenly she collapsed and then immediately called back.
Okay, I can't feel any time. Okay. Probe saturation is not coming.
Probe is fine.
How many weeks? 38.
She's 36 years old.
Okay.
She's term now.
She's term. She's in labor or else she was.
She was very young.
We are in labor.
Okay.
Okay, step. Okay, we don't have time anymore. Yeah, because. From your side, you have something for yourself. Okay, we'll call for help. Okay, start CPR. Now she is in use. Now she is 36 weeks pregnant. She was actually bearing down, it seems. So suddenly she got collapsed. Her heart rate when I came in was like 29 milligram, and then there is no pulse. I mean, I wouldn't feel the pulse also. Yes.
Okay, I am the team leader here. I'll
start CPR.
Yes. We intubate the patient. Brother, estimation. Brother, keep ready adrenaline and all.
No anesthesia.
Once 2 minutes, just
keep the time. Brother, keep adrenaline ready. When I tell you, give the adrenaline. Anna.
30 minutes. 30 seconds.
There is no anesthesia machine. There is no anesthesia machine. There is no anesthesia machine. You can't check it. You can't use that. Brother, you adrenaline.
Brother, afternoon. It is in my plus one. If I get SHS is decreasing. If you get SHS.
You give a address. Ready with that. Check the scope ready. Check the tube ready. Change over the page. You keep that time. You want me to shift the patient to Goa or we can?
If it is quick, we can shift the patient quickly. We can. If it is not, we will perform here.
Yeah, you're perform here. I can't shift the patient in 5 minutes.
Blood pressure. Antibiotic. Give antibiotic.
Defibrillate. Ma'am, can I get one of your OG PGs for help, please? Can everyone check the IV line? That's all.
Situation is exactly no more starts.
Everyone stop. Everyone away from the gate. I'm clear, all clear. Shop delivery. Continuously clear. Give one dose of adrenaline, please. If you are tired, I'll secure the gate.
Yeah, wait.
Okay?
Thank you.
Come on. Yes. Right? What was your feeling?
We missed few steps.
Okay, is it because they said that or? Now you're thinking, no, don't worry about it. So actually, to be fair, I didn't think it was that bad. I thought there were elements of good steps that were taken, which I thought was to be appreciated. Now, I'm going to take a slightly different approach to this debriefing. So the difference being that this time there were how many? Six of y'all in there? Seven in there. So the reason why I allowed 7 people to go in is that I don't know whether how many of you have experienced a cardiac arrest situation? Any cardiac arrest situation? I hope everybody has. Agree. How many of you have experienced a cardiac arrest situation on the labor ward or labor ward theatre or anything like that? Okay, not many of you. Right, okay. But when you've had it, how many people have appeared? 1, 2, 10, 20? 4 people.
Crowd will be there.
The crowd will be there. All the passers-by will want to be there because it's so rare, everybody wants to help. So one of the things I wanted to say was that there is a perception that the more people there are, the more help you can get. Okay? So let us explore that a little bit further. Can the 7 people who are part of this scenario stand up for me, please? Okay. The rest of you, I want you to turn around, or whoever you want to think. I want you to point out to me who was the leader. All of you. I know it's a bit rude, but you can do that. Okay? Who was the leader? I want all of you to point out. Who? The yellow one? Then somebody else was pointing out to somebody else. You didn't find any leader? Yellow? Keep pointing out because I don't know, otherwise I have to ask each of you. So the girl in yellow, okay? Anybody else? What about others? Everybody thought the person in yellow was the lead. Yeah? Is anybody else who's in disagreement? I thought somebody pointed out there. No? Okay. So were you the leader then? For the cardiac arrest situation? In there, were you the leader? Did you think you were the leader? Yes. And what grade are you and what you're anesthetist? Second year anesthetist. And how did you become the leader? She's also a senior. And we had all these seniors. You are the same batch. But still, you are also thing. So what I'm trying to say here is, what was interesting was, I didn't think she was a leader. I thought she was a leader. Because she was giving the instructions. Before she came in, who was a leader? Right. Okay. And then when did the leadership get handed over? When you walked in. Correct? Did you hand over the leadership to her?
Currently, I set the situation.
Yes. And then, were you expecting somebody else to take over from you? Okay, you were quite happy that she took over. So then.
No, I was also part of that, but I need some help. So.
Yes, absolutely, absolutely. So one thing I will say is that when you have all of this, okay, so so you were leading what? You were leading the whole scenario? Which bit of only the cardiac arrest. Correct. Okay, that is the way I also perceived it. What were the other aspect of the scenario that was happening as well? The obstetric side. So who was leading the obstetric side? Can you find out? The middle one. Anybody else? Was there a leader on the obstetric side? How many of you thought there was a leader? Raise your hands. Only one person. Now, what about the two people who pointed out at the middle? You thought there was a leader. Okay. The rest of you thought there was no leader? Why did you think there was no leader?
Because I didn't see anyone pointing, if the person is not pointing anyone to just do this or that.
Okay, so there's nobody actually.
Proper communication.
There was no vocalizing that, giving instructions. Okay. So what I wanted to ask is, sit down please, thank you. So it's one patient, right? So there are two patients there. Only one patient, right? And yet you had divided it into obstetric side and anesthetic side. So anesthetic side was going one side and obstetric side was going in parallel. And the two didn't meet. Isn't that interesting? So the obstetricians didn't feel that they wanted to participate in the cardiac arrest algorithm. You didn't want to participate in their decision making. Why is that? So why is it that you allowed them to make decisions on the obstetric side without involving yourself in that decision? Why do you think they did that?
They won't. That is a different specialty. I don't think they are well equipped to do what they do.
And we are well equipped to do what we are. So you're basically saying therefore that they are not capable of doing resuscitation, they're not capable of doing ALS algorithm. Do you get taught ALS algorithm? Yes or no? Do they get taught ALS algorithm? Or BLS? Okay, BLS. You get taught. So they are capable of doing it.
We all department took class.
You may have taken the class, but looking at the response, I don't think they remembered any of what you taught. There's a bit of a doubt in their things. There's an assumption that anesthetists are more capable of doing it, and therefore it is better left to them. I'm not arguing with that point, but if there is an expectation that that is the reason why you left it, then that is also acceptable. But there was no coordination in that. Okay. Let me just ask you, if there was no obstetrician there who had arrived, would you have called for an obstetrician? Let's say for whatever reason that there wasn't, obstetrician was busy in theatre and there's a cardiac arrest which happens on the labor ward, you get called, you start cardiac compressions because you guys are the most experienced in doing it. Would you call for an obstetrician at any point in time? You would? Why? Right. And what is the decision that has to be made by the obstetrician? Yeah, deliver the baby. What do you call that as when a cardiac arrest happens? And how quickly does it have to happen? 3 to 4 minutes. Yes. Okay. So I'm assuming, since according to them you can't do cardiac compressions, the one thing you can do is perimortem cesarean section, right? They tell me that you should have done it in 3 minutes. Is that what you are taught? Yeah? The answer should be yes. There's no arguing with the evidence. Did you do it in 3 minutes? I need an answer from you all. Did you do it in 3 minutes? I'm going to wait for an answer. Did you do it in 3 minutes? I can't hear the answer. So you did not do it in 3 minutes. Either they don't know what I'm asking or they're not answering that. So did you do it in 3 minutes? Okay. Since you don't know there is a reason why I'm asking that. Exactly. You do not know whether you did it in 3 minutes or not. Because who's watching the time? Who's watching the time in this scenario? Were you watching the time? They're all looking at you. So, were you watching the time? Correct. So he keeping the time during resuscitation. You were keeping time for them because they asked you to keep for them. But that is a different unit. You can't keep time for them. And also it's a different patient. So you can't keep time for them. I'm being a little sarcastic here. What I'm saying is, here was somebody who's a scribe who was keeping time for your resuscitation efforts. The same time applies there. No, I'm not saying that. Were you aware that he was keeping time? Were you aware they were doing compressions? And were you aware they were counting as they were going along? I don't think you were. Can we just go back? Can we go to the, yeah? Not within the individual specialty. Yes, thank you for that. Second?
Like you take the initiation of taking the decision and then forwarding it to the respective order.
Yes, yeah. So that's the communication between the things, yeah. Then another one? Timing. Yeah. So being aware of the time, having a person to scribe it and keeping on top of the time so that you know if you are doing any time critical steps of every day. Anything else? Sorry, yes. Yes, 3 minutes, very important, yeah.
You don't have to actually wait for the rhythm to be flat rate to CPR and your average heart rate of 20.
Yes, true. There's no cardiac output. Then you can start as well, absolutely, because there was a bit of a lag. As I was waiting, because the heart rate was really down, there was no blood pressure. The cycling, there was no blood pressure, there was no saturation either. But they were waiting for it to go flat before they started. Yeah, fair point, yeah. Okay, so very good. Thank you very much for your attention today. Any final points, sir, ma'am?
One thing on
Yes.
is that during the state efforts, we have to prevent the dietary problems. We have to do either manual
Yes, uterine displacement. Yes, absolutely. So there is a handout that has been given to you. The intention was for you to actually be thinking of what were the things that you were doing, but this is the checklist as well. So this particular case, this is a real life story of
Dr. Mayura T. Mayuri T. Dr. Sonia Dorothy. Dr. Sudarshan R. Dr. Vetrivel. Dr. Shilpa. Dr. Jisha. Dr. Kirba Devi. Dr. Rohit R. Dr. Vignesh A. I would like to call upon Dr. Ravindra Bhatt, Professor of IGMC CME, to join the ceremony. Dr. Jayaprakash. Dr. Gokula Varsini. Dr. Gautam. Dr. Harini P. Dr. Neena John. Dr. Hanshika Ravichandran. Dr. Abhinaya R. Dr. Mohanapriya R. Dr. Abhinaya T. Dr. Chandrika K. Dr. Rupa Srimani. Dr. Yuvasri. Dr. Devasat Rajababu. Dr. Devi Sri. Dr. Anita. Dr. Balaji C. Dr. Ashika. Dr. Shraddha Lunawat. Dr. Ramadevi, Dr. Bonesh, Dr. Sita Chandramukhu, and Dr. Anup Chandra.